Hi sir, good evening.
Good evening.
Actually, I have one doubt in one case.
Okay.
Actually, a case came yesterday, which is referral. The dog has symptoms of heavy breathing. So that's the one complaint. Age is 7 years. Breed is Dalmatian.
Okay.
So when I examined the heart, so I noticed muffled heart sounds. I didn't find
Okay.
any murmurs. So immediately I have done X-ray, BP, and echo.
Okay.
BP values are high. It is average 200.
Okay.
And X-ray revealed I didn't find any pulmonary infiltration kind of things.
Okay.
But heart is rounding. Both bilateral enlargement is there.
Okay.
In echo, I found left ventricular contractions are very minimal, and
Okay.
wall also thinning,
Okay.
and there is no regurgitation in both mitral and tricuspid wall.
Okay.
Yeah, but one of the anterior leaflet of the mitral wall is slightly thickening.
Okay.
So on one more thing I have noticed in the echo, slightly right ventricular enlargement is there.
Okay.
Based on the calculation of the left ventricle, right ventricular. So when I checked in other view, I noticed in dilation of the pulmonary aorta also.
Okay.
So based on this, in the X-ray, I didn't find any pulmonary infiltration kind of things.
You mean pulmonary artery was dilated?
Yeah.
Okay.
So, and in echo, I noticed pulmonary hypertension and BP, systemic hypertension. So can I know the exact? It is a cardiac origin or cardiopulmonary origin or pulmonary origin only instead of not cardiac. So I need to differentiate these three things.
Was
exactly
there-
what it will be.
Okay. Was there any ascites?
No ascites, sir. One more thing I have to forget to tell you. I have done ultrasound also for safe side.
Okay.
In that, I found heterogeneous echo texture of the liver, slightly fibrosis. There is no
Okay.
cyst in the liver and mildly hepatomegaly, and there is no ascites. And spleen size also normal. Yeah, remaining abdomen, all other organs are normal. Yeah.
So let's go step by step. First, you saw that there was heavy breathing. The patient had heavy breathing, right?
Yes, sir.
And heart rate is reduced. Heavy breathing is there. Technically, we expect that breathing and heart rate should increase, but here heart rate has reduced. So we need to rule out either cardiac function has got suppressed, okay, and also rule out cardiac contractility, why it is low. So you did 2D echocardiography, fine. Heart rate can also be less due to thyroid issues, and also that also we should rule out. Okay, so heart rate was reduced, there was no murmur, so no mitral valve or maybe initial mitral valve issues or tricuspid valvular issues, fine, but definitely not evident. BP is very high and the heart rate is reduced. Okay, that means there is some contractility failure, isn't it? Blood pressure is high means, suppose if this is my heart or our patient's heart, here tricuspid valve, mitral valve, the blood receives through superior inferior vena cava right atrium to the right ventricle, goes to pulmonary artery to the lungs, received and oxygenated blood through pulmonary vein, left atrium, comes back to the left ventricle and out through the aorta. Okay. Now if the heart rate is less means either these two pumpings have reduced, maybe due to the systemic hypertension. You have already said that. How much was the BP, doctor?
200, sir.
200. So 200 systolic BP means there will be resistant for the left ventricular aorta, left ventricular outflow through the aorta. Resistant will be there. So these guys will be finding it difficult to contract, and pulmonary hypertension is there, you told. So there will be contractility problem issues with the right ventricle also. This will end up, this moment blood goes out, pulmonary arteries are dilated, and that due to this dilatation, that means there is excessive fluid over here, and pressure also. This pressure will give resistant to my right ventricle blood also. It will lead to right ventricular dilatation. It may also lead to, or this may happen due to initial left ventricular dilatation. It is a case of DCM. Okay, now X-ray you told there was a dilatation of both the side. Very good. Yes, so that is what it explains. Then what is it? Echo showed there is a dilatation, pulmonary artery hypertension was there. Ultrasound shows liver echogenicity is high, means this causing congestion backside. Reverse congestion means our liver is getting congested. Liver getting congested means it will lead to hypoxia. Hypoxia will lead to cellular injury. Cellular injury leads to fibrosis. So if not in early stage, severe fibrosis, till that too sometimes patient don't even survive. Like in human beings who drink a lot, alcoholic patients, we get a lot of fibrosis. But in dogs, you may see heterogeneous hyperechoic pattern. So that explains why you saw hyperechoic pattern or heterogeneous pattern in the liver, hepatomegaly, but not ascites. Maybe it is an initial case. Okay. So now the most important question is, how do we treat this case? So best I would recommend is to let's deal with the hypertension first. Okay, if the systemic hypertension is high, there is pretty good chance, doctor, my RAS will get activated soon or later. My RAS will get activated soon or later means, has it got already activated, we will do KFT. If the renal values are high, SDMA is high, that means in the Bowman's capsule, what is happening is my efferent vessels are okay, but efferent vessels too much vasoconstriction. This one is causing too much of GFR, too much of increment in the GFR, but in the end of the day, it will causes again reduced in cardiac output because of the consequence of chronic RAS activation. We need to counter this vasoconstriction. So we will either give angiotensin convertase enzyme inhibitor or angiotensin convertase enzyme blockers. Blockers are telmisartan, losartan. You can give that, or inhibitors like enalapril, benapril and all. So systemic hypertension will deal like that. And pulmonary hypertension, you give something called sildenafil. Sildenafil will cause dilatation, further dilatation, and prevent vasoconstriction of the pulmonary arteries, and dilatation will lead to reduction in the pressure over here. Hence my right ventricle will get relaxed. Otherwise this will also start showing consequences, congestion consequences in the liver. Systemic hypertension will increase. Rest of what we can do is in the short axis view. Okay, typically when we go with our short axis view like this round shape which is there, na doctor, the pressure in the left ventricle is always more than the pressure in the 20. Practically there will be pressure of 100 or 140, 120 by 80, isn't it? 100 of the pressure will be there. Right ventricular pressure will be hardly 1/4. 25 is the pressure normally. So because of this high pressure, there will be slight bulge in the intraventricular septum. This bulge will be there in the short axis. This bulge becomes parallel, that is why we say inverted D shape. Okay, we get D shape. So to confirm it is the last stage or very advanced stage of pulmonary hypertension, sildenafil, how much dose or how many dose or till when should we give it? Short axis view will give you an idea that if this D shape has become a flattened septum, we call it, isn't it? This flattening has still there, means the pressure in the right ventricle is still there. This pressure is forcing the interventricular septum this side, hence this bulge is getting flattened. In short axis it is very evident. Long axis you may sometimes not be able to focus it properly if the right ventricle is not properly dilated, patient is moving. Short axis is easier. This D shape is a pathognomic thing. Pulmonary artery dilatation, D shape, these are pathognomic of pulmonary hypertension in advanced case. So this will help you in the line of treatment. And first one thing is heavy breathing can also be due to pulmonary problem. So you do NT-proBNP blood test to rule out whether the origin is, all this origin is cardiopulmonary, only pulmonary or only cardiac. Okay.
Yeah. Got it, sir.
Thank you.
Thank you.